So, good morning and a warm welcome to all the dignitaries present here. I am Kashish from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by jointly Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation, USA. So, the focus of today's session is low flow, low gradients. Well, to start with today's Sunday TEE session, I would like to present a short inauguratory video. Just allow me a moment.
Good morning and welcome to the Sunday tea breakfast session. Thank you so much for joining us. As you are aware and already mentioned, this event is being conducted under the auspices of Indian College of Anaesthesiologists, Indian Association of Cardiothoracic Surgeons, Global Heart Care Foundation, and International Society for Cardiac Ultrasound. And I would like to also mention that we have completed 4 years of the regular Sunday TE sessions, started from 2020 December, and uh, we are finishing this year. So I would like to congratulate you and wish you all the best for the forthcoming New Year 2025. And And we have two eminent faculty from our nation, Dr. Sanjivani Inamdar and Dr. Jitin Narula, who will discuss and deliberate on the subject of low flow, low gradient aortic stenosis. It's a very complex subject, but I think we'll have a clear understanding at the end of the session. With that, I would like to request Dr. Sanjivani to take over and conduct the session. And before I actually hand it over to Sanjeevani, I would request you to put your comments and the questions in the chat box. We will get back to you at the end of the session. Thank you so much. And Dr. Sanjeevani, please.
Good morning, Dr. Murlidhar. Thanks for inviting me for this end of the year session, and that too to moderate eminent speaker, a very good cardiac anesthesiologist, Dr. Jitin Narula from Delhi. If I introduce him the proper way, it would take me an hour. His biodata is so huge, and I have listened to him many times. A very, very nice speaker. He knows his profession. He is very expert in that, and he is DM cardiologist, DM cardiac anesthesia. Then he finished his IACTA and FTEE and European Society degree also. And he is co-author in many chapters along with other eminent doctors. And many things he has achieved in his life. So this is a difficult topic, and no wonder Dr. Murlidhar has given him this topic because he has been expert in his field. So this is low flow, low gradient in aortic stenosis. Jitin, please proceed.
At the outset, I would like to thank Murlidhar sir for being and organizing this event for the last 4 years, and arranging many other academic activities for students all across our country and even abroad. You're doing a phenomenal job in spreading awareness and education, sir. Thank you, ma'am, for your for giving a very kind introduction and speaking so highly of me. I hope I am able to do justice through this session that I'm going to present. So, I am going to talk about low flow, low gradient aortic stenosis over the next half an hour. And so, basically, it, I hope my slides are visible and audio is clear.
Yes,
Um,
it is visible, but a little louder, please.
okay, ma'am.
It is, slides are visible. You are in, not in presentation mode yet, but go into presentation mode.
Is it at, my screen is playing on the presenter on the full screen. Is it visible now?
Uh,
Now.
Rajiv, it is in not in presentation mode, isn't it? Rajiv?
Are the slides playing full screen, ma'am?
No, no, no. They
It's
are,
not full screen.
Now?
no, I think you can de-share and share again if that
Okay.
works. I don't know. That is what Rajiv keeps telling us.
Can you please share the share screen option once again? And it has disappeared from my.
Just give the access, please.
Yes, sir, done.
Is it on full screen now?
Yes, now you are on full screen.
Okay. So the etiology for low gradient aortic stenosis also is pretty much similar to our routine the high gradient aortic stenosis, and it mostly occurs either secondary to calcified aortic stenosis, where we see calcium deposits occurring in the center of the leaflets, or it could be in 24% of the cases secondary to rheumatic aortic stenosis, where there is commissural fusion and leading to a triangular shaped orifice, or it could be secondary to the bicuspid aortic valve, which is seen in around 35 to 40% of the patients. The American Heart Association has provided a functional staging for aortic stenosis, which helps to differentiate between various subtypes. Stage A is usually patients who are at risk of developing aortic stenosis. Stage B is progressively developing aortic stenosis, which is mild and moderate. Then stage C has asymptomatic severe aortic stenosis, which includes the normal LV function C1, and C2 as the aortic stenosis asymptomatic severe AS with LV dysfunction. The stage D, which AHA has suggested, consists of symptomatic severe aortic stenosis, and it has three subtypes, which is D1, which is the normal flow high gradient severe aortic stenosis, and the second one is the D2, which is low flow low gradient severe aortic stenosis with low ejection fraction, and D3, which is low flow, low gradient, severe aortic stenosis with normal or preserved ejection fraction. So, this is a basic outline of the discussion that we are going to have, mostly about the D2 and D3 levels of a functional classification. And more importantly, it is also important to distinguish these D2 and D3 the low gradient aortic stenosis with the pseudo severe aortic stenosis. All of these I will describe over the course of my presentation. A quick recap, since I'm not going to go in details of normal flow, high gradient severe aortic stenosis or the classical aortic stenosis. It basically involves the routine severe aortic stenosis, which we see which is characterized by mean aortic gradient of more than 40 millimeters mercury, a peak aortic jet velocity of more than 4 meter per second, aortic valve area of 1 less than 1 centimeter square, and an indexed orifice area of less than 0.6 centimeter square, and the dimensionless velocity index of less than 0.25. This is the classical severe aortic stenosis, or the normal flow high gradient severe aortic stenosis. However, in a subset of patients, there are certain discordant findings which we find during the echocardiography, which may include around, and this is almost seen in 40% of the patients, where an aortic valve area may be less than 1 centimeter square, or an indexed area may be less than 0.6 centimeter square per meter square, which is consistent with severe aortic stenosis. However, there may be a mean gradient which may be less than 40 millimeter mercury, or there may be a peak aortic jet velocity which is less than 4 meter per second, which is consistent with only mild or moderate aortic stenosis. Now, this is known as the discordance. And first step here is to recognize whether this aortic stenosis is actually severe or it is moderate. So why this distinguishing is important? Because over the last few decades, the studies have shown that patients who have low flow, low gradients in their echocardiography evaluation with severe aortic stenosis, these patients tend to have a poorer perioperative outcome. They have a higher incidence of perioperative cardiac events, a requirement for inotropes, increased ICU length of stay, increased mechanical ventilation. All these cardiac events have been found to be higher in patients who have low flow and low gradient in comparison to the patients with high gradient severe aortic stenosis. So how do we proceed a patient? This discordance is that, and why the transvalvular gradients are low despite the small valve area? It's mostly because it could either be due to certain measurement errors, or a small body size, or that the cardiac output or the flow is actually low. So we first go about doing the first thing first, that eliminate our measurement errors. Just check again that if the estimation, the echocardiography caveats and operator dependence, which we routinely talk about, that echo is operator dependent and there may be human errors involved. So we first need to go back and correct our measurement errors, because estimation of the LVOT diameter, which is the most common pitfall, is very difficult to perform. It may be easy in a patient who has normal aortic valve morphology, but if the patient has severe calcified aortic stenosis, it becomes extremely challenging to measure the left ventricular outflow tract in the presence of calcifications, in the presence of disformed aortic annulus. So it becomes very challenging to measure the LVOT diameter, and the biggest problem is that the LVOT diameter in the continuity equation is squared. So any even 1 or 2 millimeters of error becomes a squared error, and that leads to a miscalculation of our gradients. The other echocardiography caveat that we face is the alignment of the Doppler beam. So that's also very important. We need to just go back and check our assessments, that whether the LVOT pulse wave Doppler was properly aligned, whether the continuous wave Doppler across the aortic valve was aligned, and the waveform that we have used for measurement of the gradients are appropriate to the and they're appropriate, and the Doppler beam alignment is good enough to provide the accurate data. So once you've ensured that, then we think more about it being low flow, which is defined based upon certain definitions provided by the American Society of Echocardiography and European Society of Cardiology, which includes a stroke volume index of less than 35 ml per meter square, or a cardiac output of less than 3 liter per minute per meter square as diagnostic criteria for calling it a low flow. This is usually calculated using the pulse wave Doppler across the left ventricular outflow tract, and calculating the left ventricular outflow tract LVOT VTI, and then multiplying it with the LVOT area, which gives us the stroke volume, which is calculated in the left ventricular outflow tract. So low gradient aortic stenosis may be prevalent to a percentage may of this condition may vary anywhere between 3 to 35% of the cases that we see of severe aortic valve stenosis. This discordant echocardiograph data regarding AS severity creates a confusion and uncertainty about actual true severity of the disease, and thus unclear therapeutic conditions whether to manage medically or to proceed for surgery, and what type of aortic valve replacement, whether transcatheter or surgical valve replacement. So if there is a discordant planimetry area or the continuous wave equation, and then the mean gradients are less, we follow a stepwise approach for measuring for further clarification. So first step is that we ensure that the blood pressure is between 120 to 140 millimeters mercury during diagnostic testing. We then exclude our measurement errors that I have previously highlighted and index the aortic valve area to the body surface area. Then calculate the ejection fraction using the Simpson's method, and then calculate the transvalvular flow or the stroke volume index. So then we would be able to identify which subtype of low gradient aortic stenosis are we dealing with. So once we have an aortic valve area of less than 1 with a mean gradient of which is less than 40, which is the low gradient aortic stenosis, as I said, we proceed towards calculation of the LV ejection fraction. If the LV ejection fraction comes out to be less than 50%, we then call it as the classical low flow low gradient aortic stenosis. And if the ejection fraction is more than 50%, we then calculate the flow, which is the stroke volume index. And if it is less than 35 ml per meter square, we call this as the paradoxical low flow, low gradient normal ejection fraction. And if it is more than 35 ml, we call it the normal flow low gradient severe aortic stenosis. Now, why all these classifications are important is because each variety of these low gradient aortic stenosis has a different prognostic and different therapeutic implications. Um, so moving on to the stage 2, that is the low flow, low gradient severe aortic stenosis with low ejection fraction, or the classical low flow, low gradient severe aortic stenosis, which we very frequently hear about. We have seen that the mean gradient is less than 40 millimeters, the stroke volume index is less than 35, and the ejection fraction is also low in the presence of a severely stenotic aortic valve. So this is a situation which we see, and it is found in about 5 to 10% of the patients with severe aortic stenosis. It is more prevalent in men, and what we see that there is a coexisting coronary artery disease seen in 49 to 76% of these patients. These are those patients who start as normal flow, high gradient severe aortic stenosis, and they eventually transform into low flow, low gradient severe AS with reduced ejection fraction through a number of mechanisms that happen over time. So any patient with high gradient aortic stenosis who is subjected to oxygen supply demand mismatch with severe aortic stenosis, reduced capillary density that happens, which causes chronic subendocardial ischemia and interstitial fibrosis, eventually leading to an afterload mismatch, which causes the classical low flow, low gradient severe aortic stenosis to develop. Eventually, the left ventricle fails to keep up with the high pressure gradient and it decompensates. The LV, or the left ventricle, then dilates and the stroke volume drops, and the LV ejection fraction also falls, causing this low flow, low gradient situation. This LV systolic dysfunction is attributable to the afterload mismatch and must be distinguished from a primary myocardial dysfunction with only moderate aortic stenosis, which is important with this situation, which is called the pseudo severe aortic stenosis. So we need to differentiate true from pseudo severe aortic stenosis, in which when in the pseudo severe aortic stenosis, a ventricle pathology is the primary culprit, and it is usually associated with the cardiomyopathy, which is either ischemic or idiopathic or secondary to some myocarditis. And this myopathic ventricle fails to generate adequate blood flow to open the aortic valve sufficiently. And the gradient across the aortic valves are low related to lower transvalvular flow, and this produces a hemodynamic picture which is similar to the low flow, low gradient severe aortic stenosis. This distinction between the true severe and the pseudo severe is also very essential because patients with true severe AS will benefit from aortic valve replacement, whereas those with pseudo severe aortic stenosis may not, and they are candidates for medical management. So how we differentiate between these two is on the basis of a dobutamine stress echocardiography, which is done with the help of a measurement of aortic velocity and mean pressure gradient and valve area at baseline, and with incremental dose of dobutamine up to from starting from 5 mics per kg per minute and then going up to 20 mics per kg per minute under appropriate clinical and hemodynamic monitoring. The mechanism is that the dobutamine recruits myocardial contractility in normal and hibernating myocardium, and it enhances the stroke volume and transvalvular flow. So if there is a 20% rise in stroke volume at peak dobutamine levels, these are known as patients who have stroke volume reserve or they have contractile flow reserve. The patients who have true severe aortic stenosis or the classical low flow, low gradient severe aortic stenosis, the valve area being intrinsically restricted cannot open any further because the aortic stenosis is true and it is severe. And in this case, the recruitment of further myocardium would cause an increase in the velocity, which will go up by 4 meters per second and an increase in the gradient of more than 40. But the valve area continues to remain less than 1 centimeter square. However, patients who have pseudo-severe aortic stenosis, which was secondary to some myocardial dysfunction or pump dysfunction, there is an increase in the valve area as the volume flow rate increases with recruitment of more myocardium with the use of dobutamine and with little or no change in the transaortic velocity. So there would be an increase in the effective orifice area of more than 1, and the velocity, the gradients continue to be less than 40 millimeters of mercury. So this is how we differentiate the true severe AS with the pseudo severe AS. Now, why this differentiation is important before we proceed for surgery is because the operative mortality for AVR in patients with low ejection fraction, patients who do not have a contractile reserve versus patients who have contractile reserve, it has been seen that the early surgical mortality is almost only 5 to 7% in patients who have flow reserve, whereas the surgical early mortality is almost 32 to 33% in patients with no flow reserve or no contractile reserve, and the survival benefit of 5 years is 88% in patients with flow reserve versus only 10 to 25% in patients with no reserve. So that's how the other technique besides dobutamine stress echocardiography is to use a projected orifice area, because DSE itself may be inconclusive in about 30 to 40% of the patients, as increase in stroke volume may not be sufficient to completely normalize flow if the myocardial recruitment is not sufficient enough. So we use a projected effective orifice area calculation. It is a calculated value, which is you calculated from resting aortic valve area and peak aortic valve area during the DSC that would have occurred at a standardized flow rate of 250 ml per second. And it is then subsequently used of complex formula is used to derive the value, and it is found that projected effective orifice area better predicts the actual hemodynamic severity of pseudo versus true severe aortic stenosis. Other thing that can be done preoperatively is using a CT calcium score, which is quantification of aortic valve calcium by CT imaging, which is also useful in patients with low flow, low gradient aortic stenosis of uncleared severity with either normal or reduced ejection fraction, and it is highly accurate and reproducible. The advantages are that it is independent of any hemodynamics or flow, and it does not require administration of any stress or contrast agents, and this assesses the anatomical rather than the hemodynamic severity of the aortic stenosis. The amount of calcium, as we can see in the region of the aortic valve, is quantitated using the modified Agatston method, and the aortic valve calcium score for true severe aortic stenosis is more than 1300 in women and in more than and around 2000 in men, and it strongly correlates with hemodynamic severity, progression, and clinical outcomes. So once we have concluded identifying the low flow, low gradient severe aortic stenosis with reduced ejection fraction, we then move on to the second subset of low flow, low gradient aortic stenosis, which is with the normal ejection fraction, which is the stage D3 of the functional stage provided by the American Heart Association. In this, we call it also as the paradoxical low flow, low gradient, and it is seen in around 5 to 15% of patients with severe aortic stenosis, and it is more prevalent in women and elderly females. Now here we see that the aortic valve area is less than 1 centimeter square. The gradient is low, but however, we find that the ejection fraction is normal and the flow is less than 35. So the paradox here is that there is normal ejection fraction, but the forward flow is reduced. Now, how this happens is because this also is seen that patients who have high gradient severe aortic stenosis, who are subjected to excessive left ventricle hypertrophy over the years, and also may have concomitant mitral regurgitation or stenosis with tricuspid regurgitation or stenosis and atrial fibrillation or other infiltrative cardiomyopathies. These patients are the one who develop towards the paradoxical low flow, low gradient severe aortic stenosis. And because in the presence of chronic exposure to a high level of afterload eventually exceeds the limit of compensatory mechanisms that the left ventricular has, and this leads to an intrinsic impairment of myocardial function, and this causes a decrease in eventual decrease in the cardiac output, producing a low flow. These patients have excessive concentric LVH, and we can see that the hypertrophies are beyond is way too much, and which subsequently leads to a restrictive pattern or a restrictive physiology in response to hemodynamic stress. These patients have small LV cavities and have low stroke volume secondary to the smallish size LV cavities, despite having a preserved ejection fraction. So, the left ventricle ejection fraction alone assessment in these patients may not be enough in this era. And that's because ejection fraction is a relatively poor and misleading parameter in assessing as using as a sole parameter for assessing LV function. So the AHA has suggested that if we have the facility for measuring global longitudinal strain, it may be a sensitive parameter which helps to unmask the apparently normal LV ejection fraction in these patients, which is reduced to a larger extent due to fibrosis along the subendocardial layer. These findings suggest that the paradoxical low flow, low gradient AS is more advanced stage in the hemodynamic spectrum of severe AS and thus classified in the guidelines as stage D3. I'm sorry, it is. So the global longitudinal strain may be an additional parameter which can help to distinguish between the D2 versus D3 of low flow, low gradient aortic stenosis. So GLS can detect impairment of LV systolic function when ejection fraction is still normal. And this can help to identify patients with severe aortic stenosis who are at higher risk of death despite preserved LV ejection fraction and have no or mild symptoms. However, further studies are recommended to confirm its prognostic value. And it has been shown that patients who have GLS of less than 15% have a higher adjusted mortality while undergoing aortic valve replacement. There's another third subtype of the low gradient aortic stenosis where we see quite often in our theater practice also, where there is a low gradient as seen on echo with less than 40 millimeters mercury with a severe aortic stenosis. However, there may be a normal flow, which is characterized by a stroke volume of more than 35 ml and ejection and a normal ejection fraction. So this is called as the normal flow low gradient aortic stenosis, where there is a flow of more than 35 stroke volume of more than 35 ml per meter square in the presence of low gradient and severe aortic stenosis, and it accounts for around 15 to 30% of patients with severe aortic stenosis. It has poorly defined entity with unclear pathophysiology, there is a gradient discordance due to inherent inconsistency in the guidelines criteria, and there are measurement errors or a small body size. This is associated with a long-standing, poorly controlled hypertension, which causes a reduced arterial compliance, causing faster arterial wave reflection from the periphery. And this leads to an early reflection of the arterial wave at the end of systole, which dampens the transvalvular gradients, causing lower gradients as we see, and which is independent of the transvalvular flow. It is likely that these patients may have only moderate aortic stenosis. Now, how echocardiography determines the prognosis in such patients is because the importance of establishing the diagnosis of low gradient severe aortic stenosis is reflected in differing prognosis to high gradient, different prognosis that it has in patients with high gradient severe aortic stenosis. In patients who have medical management, the only 2-year survival is approximately 40 to 60%. The 30-day mortality of aortic valve replacement is high depending on the presence or absence of flow reserve, which may be 8% to 33%. Patients with contractile reserve have significantly improved long-term outcomes after aortic valve replacement, which may be either transcatheter or surgical aortic valve replacement. However, patients with poor contractile reserve, like patients with pseudo-severe aortic stenosis, are associated with high operative mortality and they are to be managed medically. So, when it comes to managing these patients, it's the heart team that plays a central role in selecting the most appropriate modality of treatment, whether it is TAVR or surgical aortic valve replacement versus medical management. It's no individual cardiologist or cardiothoracic surgeon taking the call. It's the TAVR heart team, which which includes a comprehensive risk stratification algorithm and takes into consideration the STS score, the frailty index, major organ compromise, and produces procedure specific impediments. The treatment options include SAVR in the surgical aortic valve replacement, which is routinely done in patients who are low surgical risk patients. They are subjected to SAVR. These patients have low risk of paravalvular leak, less need for valve intervention, and less need for permanent pacemakers. In patients who are at high surgical risk, they are subjected to transcatheter replacement, which includes patients which by the cardiologist are or the heart team are classified to the high surgical risk. They are subjected to the TAVR modality. This modality has lower mortality risk, shorter hospital stay. These have rapid return to normal activities. They have lesser bleeding, lesser AF, less pain than surgical aortic valve replacement. Controversy, however, exists as to what is the ideal management strategy for pseudo-severe aortic stenosis with reduced LV ejection fraction, and current guidelines, however, do not recommend aortic valve replacement. However, the newer trials, that the recent TAVR Unload trial in patients with pseudo-severe aortic stenosis also they have compared medical therapy versus transcatheter aortic valve replacement, in which they have shown that the superior 2-year overall survival and cardiovascular survival in patients who are subject to TAVR versus in patients versus medically managed for pseudo-severe aortic stenosis. So valve replacement has shown improved survival irrespective of flow rates. Patients with no floor LV contractile reserve, which is less than 20% increase in stroke volume on DSC, have markedly reduced survival compared with those who have low flow reserve, regardless of the type of treatment. And aortic valve replacement is associated with an improved survival and must be considered irrespective of flow reserve. So to conclude, low gradient aortic stenosis remains a challenging condition in terms of diagnosis and treatment. Differentiation between various subtypes is crucial for determining the prognosis. Echocardiography plays a key role in diagnosing the subtype of low gradient aortic stenosis, and patients without flow reserve have worse outcomes and high mortality. Pseudo-severe aortic stenosis in the TAVR Unload trial has demonstrated a benefit of aortic valve replacement versus medical management. And in the new paradigm, which is now moving towards treating the flow to improve the survival and well-being. Thank you.
Yes. Thank you, Jitin. It was excellent. It is a difficult topic, and I would expect few questions from the audience. And before that, I just would like to ask you, see, calculating aortic LVOT area is a big task, isn't it? Because that is the main thing which can go wrong and everything will go haywire. So is there any new method that hybrid calculation, you know about it, that you do LVOT area by some other modality and take Doppler from echo and then calculate the aortic wall area. So they are doing it now, that they are doing taking LVOT area by either 3D, that is okay, that is our part. But from CT, that is known as hybrid calculation of aortic wall area, which is giving a good result. That is number one change in the scenario recently. And another thing is valvulo-arterial ratio, impedance, valvulo-arterial impedance. That gives you, the formula is systolic BP plus mean gradient divided by stroke volume index. So when it is more than 5 is the cutoff point. More than 5, it simply tells you that the patient has a tremendous afterload, which LV is not able to handle, or we have to do something. So what we have to do is control BP. We can't do anything for mean gradient. So this is very, very sensitive and good method to manage these patients before surgery. And there are many patients of aortic stenosis with high blood pressure these days because they are quite old now. So BP is also high and gradient is also quite high. So one has to manage, but in a controlled way, of course, because you can't reduce BP in aortic stenosis, that we know, because it will precipitously reduce the cardiac output. So this is another important thing. And you did mention about transvalvular flow rate. Can you tell something more about it? Because it is the main thing which is coming up, transvalvular flow rate. You did show in one of the slides,
Mhm.
transvalvular flow rate. What is the
Transva-
cutoff point and other things?
So, transvalvular flow basically we calculate with the help of LVOT VTI and a pulse wave Doppler, which is placed in the LVOT.
No,
And
flow rate, flow rate. We all these days we are taking stroke volume index, stroke
Mm,
volume in projected aortic wall area. In that slide, you did show
mm,
You can go to your slides and show that. That's a very good way of expressing projected valve area, as well as it is more sensitive than stroke volume index.
mm.
You just have to, that formula for that is you just have to divide stroke volume by ejection time. With
Okay.
more ejection time, bad. It has
Mm.
to eject rapidly, isn't it? So
Yes, ma'am.
more the ejection time, low is the transvalvular flow rate,
Mm,
and the patient will not do well. And that is the main thing which is they are applying in low flow, low gradient, paradoxical low flow, low gradient,
mm,
because these are very notorious patients,
mm,
common in women with
mm,
severe ventricular hypertrophy and
mm,
stroke volume index. Sometimes stroke volume index is more than 35, and still the third one I think you showed, third criteria,
mm.
third group.
Third type, yeah.
Third group.
Mm,
So this transvalvular flow rate, see
mm.
that in this graph, you are showing transvalvular flow rate ml per
Second.
second. So
That's it.
250 is around 250,
Mm,
220 to 240. It is in between 220 to
mm,
240, but that is normal. And
mm,
then the projected aortic valve area, they have calculated,
mm,
and we go by that projected aortic valve area. So
mm,
transvalvular flow rate is the new thing. which it's very simple to calculate. And because one should know how much flow is coming from the aortic valve at that ejection, whatever is the ejection. So that is important concept. Can we see any question in the chat box? Anyone, faculty or other people want to ask anything? Can open your mic and please ask. It's a difficult topic. One has many concepts are there and many formulas are there.
Absolutely lovely presentation. Thank you so much. Can you hear me?
Yes,
Yes.
sir. Yes, sir. Thank you.
So I just wanted sort of a funny question. Either of you can answer. Suppose you have a patient with normal ejection fraction, but the flow is low. For example, the stroke volume index is less than 35. Can we ask the patient to have some water to drink and then you repeat the test and the stroke volume may become normal?
So we must ensure that patient is adequately under a normal hemodynamic state, should not be fasting or dehydrated for a very long time, because then, of course, it may affect our test values. Since
So
they
the volume,
are
suppose
depleted.
patient has come to the OPD
Mm,
and you find that the stroke volume is less than
mm,
35 ml per kilo per beat.
mm,
So in that case, I mean for body surface area. So in
mm,
that case, can we just increase the volume status and see is it? I'm just still thinking loudly because probably if you increase the volume, it may become the stroke volume also may become normal.
mm.
It all depends on how much is the gradient across the aortic valve, isn't it?
And stroke volume
And
is good.
if he is volume depleted, then only it would matter. Otherwise, it would not matter.
Okay. Thank you. Thank you. That's all from my side.
I just wanted to ask Jitin another one more query that I have, that if your contractile reserve is less, okay, then would it matter in tower for indication of tower? Not yes, tower. If the reserve is very less after dobutamine,
Mm. So
what one would do?
in the recent, there are two trials which are expected, ma'am, with two which are under now about to come up with their results, which are the Tower Unload trial, which they did in patients with poor contractile reserve or the pseudo severe low flow, low gradient AS. And they have shown that patients who had TAVR performed, they did better with than compared to patients who were only managed medically. So, and the results from the another important trial is that the progress trial that is still yet to come up with their results. They all it is believed that they are now moving towards treating as I said, that towards treating the flow rather than treating to improve the flow. If the tower can provide a improved flow, it will lead to a better prognosis in terms of 5-year survival and more symptom free than managing versus only on medications. So yes, in these patients, performing transcatheter aortic valve replacement should benefit. That is what the recent trials have shown, ma'am.
Sorry, my net connection was just out of order for a few seconds. So,
Mm-hmm.
what was the inference of your answer?
So
I
I will
didn't.
just share this slide, ma'am. In this,
Yes, yes. No,
yes.
what I wanted to ask you, if the um, contractile reserve is not good at all post
Mm.
OBU, would you take him for cover? That is my question actually.
Yeah, ma'am. Till now, these patients were subjected to only medical therapy. So, but nowadays, what the trials from the TAVR Unload trial, which they have specifically done in patients with pseudo severe AS,
Mm-hmm.
or the patients with low contractile reserve, they have seen that there is a superior 2 year survival, and their
Correct.
cardiovascular survival is also better than managing them medically.
Huh.
And so they have come up with the recommendations of treating the flow, improving the flow. That again, that as you had mentioned, the transvalvular flow, which can be improved with the help of TAVR. So in pseudo-severe patients or patients with low contractile flow reserve, also they have shown there is clear benefit of replacement there rather than
Correct.
managing them alone on medical therapy.
Correct. Correct. So in short, these patients with low reserve, one should make them undergo tower rather than sour. For sour, we say high mortality and all those things, but
Ye-
for tower, it doesn't matter. That is the main thing which has come up, and that is why tower is going up now.
Yes.
So even if dovitamin says low contractile reserve, you should go ahead with tower if he affords it. Okay. Another one important, which rather not out of the box, but the question is why there is so much of difference between um, calcium score for men and for women. Men is 2000 is the cutoff and women is 1200. And there
Mm.
is a scientific reason for that, of course. That's why I'm asking. It's a huge difference. Usually the EF parameters or anything is few millimeter, few
Mm.
ml difference,
Mm.
isn't it, in between men
Yes.
and women? So why
Mm.
there is such a huge difference?
They have, I'll have to,
So that is very simple actually. The women are they have more fibrosis.
Mm.
Women have more fibrosis than calcium store, and that is why the cutoff is very low. They have more fibrosis, and their valves are still stenotic, even though there is no calcium. That is why the cutoff is quite low, almost 50-40% low, isn't it? 2000 and 1200 is a big difference.
Even with less calcium, you consider them to be
Correct, correct. Because the fibrosis is more, and that fibrosis is not picked up by
TT.
MRI. CT. So that is the most important thing. And in your third group also, the blood pressure thing is the most important. You have shown it actually in your
Mm.
slide.
Mm.
So that third group. So you have to manage their blood pressure very meticulously and then go ahead. Another important question. Raju, we do have some time, isn't it? My watch is little ahead.
Yeah, we have 12 minutes.
Okay, okay. So another important thing is about this. I just forgot what I wanted to ask. Okay, here also you have to reduce blood pressure very meticulously and manage the case. Another thing which I remembered again is how do you grade when there is MR, MS, MAC, mitral annular calcification is a common thing at that age, isn't it? 80
Mm.
years, 75 years with
Mm.
severe aortic stenosis. So
Mm.
how do you how do you grade these patients? I mean,
Hmm. So, in the presence of these confounding lesions, which are either above or above stream, these gradients may become fallacious because the overlying MS or MR um,
dampen,
mask the
mark.
actual
Yes,
severity.
correct.
So this becomes a challenge in these situations, and planimetry in these situations can be a good modality to measure the actual severity
Mhm,
of the area. Gradients may be masked by the lesion above.
correct. Um, Dr. Muralidhar, you have anything to
There are a
any
couple of
question?
questions on the chat box.
Okay, okay. I'm
Kindly
not able
address
to
them.
see. I'm not able to see them.
I'll read it out. One
Okay.
is how to do dobutamine stress echo in low flow AS cases in atrial fibrillation. Can you still do the dobutamine stress in patients who have atrial fibrillation? That is one. Second is, does HOCM cases land up into low flow, low gradient AS?
So,
These are the two questions on the chat box as of now.
mm,
Okay.
Atrial fibrillation and HOCM.
Okay.
so
Jitin?
Hanji ma'am. So patients with atrial fibrillation, they are already their atrial kick is lost, and they only so it may be difficult to have a conclusive result based on dobutamine stress echocardiography. Maybe if we can control the rate to low, maybe AF with slow ventricular rate, but AF with fast ventricular rate, DSE will not have any conclusion.
Whatever
Uh,
is in the front.
Once we have AF with control ventricular rate, maybe we can
I'll
go.
be in touch with that.
Okay. What about HOCM and aortic stenosis?
So, patients with HOCM also may develop subsequent, because of the afterload mismatch, they will eventually develop a small sized left ventricular cavity, and they can also develop low gradients.
But it's very uncommon. And let me tell you, HOCM and aortic stenosis,
Mm,
already God has given one big gradient in LVOT. So
mm,
very, very rare situation, but still.
mm.
Any other question? Who you were talking to your friend Jitin? Where is he? Ask him to ask some questions.
Uh, So it was a very insightful presentation on a very complex topic, and you have done a very justice to the talk by giving a very comprehensive review about it. And a few things I liked and I learned new things. Like one thing, your slide showing the advantages of Savar and Tower are very interesting to me. Absolutely, you have hit on the nail. What are the separate advantages of Tower versus Savar? And the new thing that I learned was that in pseudo severe AS with low contractile reserve, the guidelines are changing and they are preferring medical the tower instead of medical management, because tower was having high mortality with in patients with a low contractile reserve. So that was a new thing that I knew, and it was a very
So
wonderful
I think
talk.
now the
Absolutely
paradigm is
elaborated.
towards.
Another important thing which I have already said this, that you have to reduce blood pressure very gradually, and then only you may expose the severity of the gradient. Gradient may increase or decrease according to how much is the peripheral blood pressure. So that is they have compared it with catheterization, and so the aortic gradient increases when you manage the peripheral blood pressure. So it sort of unmasking the severe aortic stenosis. So that much importance is given to blood pressure, which is a very common scenario. Parimala is there, and so many other faculties. Please ask something.
And so regarding that question on atrial fibrillation, in fact, atrial fibrillation is one of the complication during dobutamine stress echocardiography. Some
Correct.
patient may be in sinus rhythm and he develops AF during the study.
So
Another thing is that cardiologists keeps saying this, that the low dose Dobu is very safe. Uh, that is what they keep saying. I have done. I am doing these dobutamine stress echo and dobutamine studies, and really it is quite safe. And I have not seen any fibrillation, because in aortic stenosis the dose is very low. But still, you never know. You never know.
So there is a question on the chat box. Intraoperatively, how to differentiate between pseudo-severe aortic stenosis and true severe aortic stenosis, where we do not have CT or dobutamine stress echo. So I think intraoperatively the patient is under anesthesia, and I think these decisions should be made before taking up the patient for surgery. What's your comments?
No,
So
I just asked that person, is the patient is for aortic stenosis or is some other reason they have taken it? If it is
so
aortic stenosis, one has to analyze the patient fully before. But if it is for some other reason and they find stenosis over there, then it must be a mild stenosis.
I think that he is asking a patient is for AVR only because he's saying he
Then it
don't
has to
have.
be a
Yeah,
very well managed analysis before surgery. One cannot just open chest like that.
because he has mentioned we don't have CT or dobutamine stress echo. That
That
means
is
he's asking
okay,
for
but
his.
there are many other things which can tell you, like managing the blood pressure and W. Okay, they don't have W. So another important thing is which we have, I skipped our mind actually today. That is doing good question actually. You should do limited stress echo that everyone has, isn't it? And if there is increase in gradient more than 20%, and if this stress echo is not the way which we do for other patients, it is a very limited thing. The moment patient gets breathlessness or his pulse rate rises more than, 80% of THR, or before that, if he gets breathless, one should just take him down and calculate his gradient. That is the thing. That is very useful. Good question. Those who don't have CT or W facility, you should do normal stress
stress.
test. Yes, that is very important. It has been given in the guidelines.
There's a last question in the chat box related to this question only. They're asking if there's any other role of cardiac MRI in these cases, if they don't have like CT or DSC. But I think if they have cardiac MRI, they must be having other things also.
Cardiac
Mhm.
MRI comes the last.
Mhm.
Anyways, but role of cardiac MRI usually would be for any if there is a discrepancy in chamber quantification, whether it is small
Mhm.
size, large size. But all these are usually well answered in routine echocardiography.
Mhm.
And for calcification, also CT is the best. So I don't foresee
Mhm.
particular added benefit of performing a cardiac MRI.
Maybe for ejection fraction, if
Hmm.
they don't, global GLS is there, but if they don't have that, and if they have MRI by chance,
Hmm.
good. So, uh, Muralidhar, time to wind up.
I think sir has left.
Okay, okay, then.
The signal is lost. Signal is maybe
Okay,
signal is
okay,
lost.
okay. Uh, I can see Parimala there. Pooja, Pooja,
Good morning.
just ask something.
Yeah,
Just
good morning.
Hi,
Yeah.
ma'am. Morning.
we are
Very
kids.
nice presentation, Jitin.
Thank you.
Very enlightening. Thank you.
Yes.
I just want to add some points. So, in aortic stenosis, as a cardiac anesthetist, when we are coming off bypass, these are the things which can be very tricky actually. So, because there will be some amount of concentric LVH, and when we are coming off bypass, there can be false high readings. So, because many people try to come off with dobutamine and NORAD or dobutamine adrenaline, so when there is a lot of tachycardia and there's a low preload, we have a very high tendency for high gradients post-op. So for all the students, try to optimize the hemodynamics. Give some time. There'll be compliance issues. Try to get the heart rate low. Try to come down on the dobutamine or inotropes you're giving, and then it's best to reassess rather than telling the gradients are high, there must be something wrong with the valve. And this is what we usually come across when we are coming off CPB as cardiac anesthetist. These are the things to keep in mind. Heart rate and preload, these are very important, and especially in aortic stenosis where there's concentric LVH, the atrial kick is very important.
Correct,
Normally
correct.
20 to 30% contributes to the cardiac output. The atrial kick is very important. So if the patient goes into any arrhythmias, in AS, it is 40% which contributes actually,
Yes,
the
yes,
atria. So it is very important to maintain a good rhythm coming off bypass.
yes, yes.
So yes, atrioventricular pacing, not just ventricular pacing. that may not be very good when we are coming off bypass, because people tend to put only ventricular wires. Always, request the surgeon to put an atrial wire, because atrial kick is very important for any patient with concentric LVH especially. This is what I would like to tell, ma'am.
Yes, absolutely correct, because aortic stenosis with AF is a nightmare.
Yes.
No doubt about it. We just skipped that point. Good, Pooja, you reminded us.
Thank you, ma'am.
What is the time now?
Yeah, I have one doubt.
Okay, go ahead. Yes.
We say low flow, low gradient AS, but when valve area is less than 1 square centimeter, the gradient is rarely more than 40. When very severe valve reduction occurs, area reduction occurs, the gradients are not very high. But it is to be considered as severe AS, right? The flows may be normal. So the doubt is whether gradient has to be taken alone for saying it is severe, or valve area itself is enough to say it is severe AS. When there is
It's a good
discrepancy,
question. Yes.
So it's a whether it is the first step goes whether it when we have found out that the valve area is less than 1, the next we go in a very stepwise manner. The next step is whether the gradient. With this gradient, if it is less than 40, as you said, that in patients who have critical AS, maybe 0.6 or so, they very often, almost 30% of the patients, we would find that the gradients are low. So it is these patients who are we label as the low gradient aortic stenosis. Now, whether they have a normal ejection fraction, if they have a reduced, it's the classical, versus if they have a normal ejection fraction, so they're basically we are dealing with subtype of low gradient aortic stenosis. The classical high gradient aortic stenosis will always be in 60 to 70% of the patients. We see that the gradient may be 70, 90, even 100 plus the aortic gradient. So these are the high gradient, whereas the low gradients could be either a low ejection fraction or a paradoxical low ejection fraction. So that this talk was mostly about these two, finding out these two and differentiating between them on the basis of ejection fraction and flow.
so if flow is normal, ejection fraction is normal. If mean gradient is less,
Yes.
we subject them to
So
dobutamine to increase the gradient.
So this would be the paradoxical low flow, low gradient severe aortic stenosis. So which is the stage D3 in the AHA functional classification, and it is secondary to the long-standing hypertrophy that the LV cavity has become so small that it's not able to generate the gradients.
Okay.
Here I would like Parimala
Yeah.
only, na?
Yes.
See here, if it is a paradoxical low flow, low gradient situation, they are not subjected to dobutamine stress echo, because the ventricle is so small and unable to generate anything even after dobu. So they are subjected to calcium scoring. That is the main thing. And based on calcium scoring, if it is more than 2000 in men and 1200 in women, they are subjected to surgery or tower, whatever is the situation. But they are not subjected to dobutamine stress echo.
DSC per se is only for reduced ejection fractions. Whether it
Okay.
is true.
Not for this paradoxical one.
Okay. Yeah. Thank you.
Madam, can we conclude the session?
Yes. It was excellent deliberation by Jitin. It is a difficult topic, and really it takes time to learn and relearn this topic. And Jitin has done a wonderful job. And this is the last lecture of this 2024. So thank you very much, Jitin, and other participants, Parimala, Pooja, Keshav. I could see Keshav, but he didn't speak anything. But wonderful session. And thank you very much. Thank you, Murlidhar, for this opportunity. And everyone, Happy New Year for 2025. Thanks a lot.
Thank you, ma'am, for moderating the session so well. Very insightful.
Thank you. Thank you.
Thank you.
Okay. See you next year.
Thank you, Sanjivani ma'am. Thank you, Jitin sir, for this session. Miss Kashish, can you play the video, please?
Yes, sir. Sure, sir.
Please. And the last flyer, please. This is our critical care echocardiography session fellowship course. Third batch will be start from 1st January 2025. Last date to apply is for 31st December 2025. Thank you all for joining and wish you in advance a very happy new year. Thank you for joining all.
Thank you. Thank you very much.
Ms. Kashish, you can end up the session, please.
Thank you so much to all the dignitaries for your wonderful deliberation. So, therefore, we are concluding with the session here. Thank you so much.
And wish you clinic people, Rituparna and Ritu Madam, and those who all are conducting these sessions. Advance Happy New Year. Best wishes to you all. Please convey
Same
my
to you,
regards
sir.
to
Yes,
everyone.
sir. Thank
Thank
you
you.
so much. Thank you.
Thank you.